Well, good afternoon, everyone. Welcome to today's Lunch and Learn presentation, Cessation Success, Evidence-Based Practices to Quit for Good. My name is Emma Parrish. I'm a health educator and tobacco treatment specialist at the Tobacco Cessation Program of the Lurie Cancer Center of Northwestern University. And I'm joined today with my colleague Liz Class, our clinical nurse, and a tobacco treatment specialist as well. So Liz and I implement our tobacco cessation program, and we work directly with patients who have cancer to help them reduce or quit smoking. Our program is directed by Dr. Brian Heitzman and Dr. Timothy Pearman, and we're supported by our supervising physician, Dr. Sheetal Kircher. And we would like to say a special thank you to our director of the Lurie Cancer Center, Dr. Leonidas Planitis, for his continued support and advocacy of the tobacco cessation program. As we do this presentation, feel free to put questions in our the question box in the chat box, and we will answer them as we go. But before we get started and dive into our presentation, Liz and I want to learn more about you, our audience. So please take a moment. I'm going to put a poll on the screen. Take a moment to select which of the following best describes you and your purpose for being here today. Great, I'll go ahead and end that. Okay, so great, kind of a little bit of everything. This is really helpful for us to see. A lot of folks wanting to learn how to incorporate cessation treatment into their job, and a couple of folks who work with smokers and want to learn more about cessation resources. Great. So for the next hour, Liz and I are going to cover current smoking prevalence and trends in cigarette use. We'll go over some evidence-based tobacco treatments available, and we'll share some local cessation resources in Chicago and Illinois. We'll take a closer look at smoking cessation during the COVID-19 pandemic and what that's looked like. And we'll end with discussing stress and smoking. So let's get started with some good news about tobacco use. Adult tobacco use in the United States is currently at an all-time low. The Surgeon General's Smoking Cessation Report found from 1965 to 2017, the prevalence of current smoking declined from 52% of adults to about 15.8% of adults. And currently in the United States, 13.7% of adults are current tobacco users. And these declines have been attributed to policy changes like smoke-free laws, the increase in access to smoking cessation resources, and FDA approved smoking cessation medications. However, while that meaningful work has been done to lower smoking prevalence, and it should be acknowledged, increases in smoking prevalence in certain populations should also be examined. The subpopulations in this graphic, those with less education, racial and ethnic minorities, individuals with disabilities or chronic illnesses, and those who are experiencing poverty, their smoking prevalence is increasing. As healthcare providers, these are subgroups that can make up a lot of our own patients that we see and work with. So encouragement from us to help them quit or reduce smoking is really important for these patients to hear. So looking at a more local scale of smoking prevalence, about 15.5% of adults in Illinois use cigarettes. So taking a closer look at Chicago, in 2016, 18.4% of adults used cigarettes and about 3% of adults used e-cigarettes. Moving into 2017, there was a slight increase in cigarette use among adults, ticking up to 18.6%. Whereas e-cigarette use declined. And then in 2018, smoking prevalence in Chicago adults dropped to 16.8%. However, e-cigarette use almost doubled. So this still leaves us with a lot of work to do to treat tobacco use, and the importance of quitting cannot be overstated. Tobacco use is still the leading cause of preventable disease, disability, and death in the United States. and smoking has been linked to at least 12 different types of cancers and can truly damage every part of the body. Which is why it is always a good idea to quit. In fact, it is never too late to quit. Quitting is beneficial at any age. Quitting improves a person's health status, lowers their risk for developing chronic conditions like heart disease. And if a person still smokes after a diagnosis, quitting can increase the success of their treatment. But better health outcomes are not the only benefit to quitting. And this brings us to a quick knowledge check in this presentation. So on your screen, a poll should pop up right now. Let's check in on your current knowledge of the financial benefits to quitting smoking. About how much money would a person who smokes a pack a day in Chicago save if they quit smoking for 1 month? Let's see your answers, or your best guess. How much money a person would save if they quit smoking for a month in Chicago. Okay, we'll go ahead and end it right here. Let's see what everyone said. So almost the majority of folks said $400 would be saved if a person who smoked a pack a day in Chicago quit for 1 month. A couple folks said 300, a couple folks said 500. Let's see. So the answer is almost $400. So majority of people did get that right. A person who quit smoking, who is currently smoking a pack a day, if they quit smoking for a month, they'll save close to $400. And at 1 year, this will look a little bit closer to $5,000. And we have a second knowledge check right here because there are a lot of other financial benefits, not just at a local level, but at a national level too. So similar question, smoking costs the United States over blank a year. Using your best guess, how much money does smoking cost the United States over a year? This one's a little bit tougher to think about. I'll go ahead and end the polling now so we can share these results. So majority of folks said smoking costs the United States over $100 billion a year. A few folks said over 300 billion. A couple others said over 900 million. Let's see what the answer is. Smoking actually costs the United States over $300 billion a year. And a short breakdown of this looks like about $170 billion in direct medical care for adults and about $156 billion lost in productivity due to premature death and exposure to secondhand smoke. So not just people who are smoking, but folks around them too definitely contribute to the cost of smoking each year. So quitting smoking results in a multitude of health benefits, but also a lot of financial benefits at a local and national level as well. So we're going to transition into our overview of evidence-based tobacco treatments. These are treatments recommended by the Surgeon General, and they are pharmacotherapy and behavioral counseling and motivational interviewing. So safe FDA approved medications for tobacco cessation have been found to be especially effective in helping a person quit smoking. And the primary preferred medications are varenicline, also known as Chantix, bupropion, and combination nicotine replacement therapy. And before we dive into talking about these different pharmacotherapies, we have another knowledge check just to check some pre-existing knowledge about these pharmacotherapies. And we're going to do this with some true or false. So on your screen right now in the polls, there are 3 true or false questions. The first one, varenicline will make me depressed. Put your best answer there if you think that is true or false. True or false, varenicline will give me mood swings. Put your best answer there, true or false. And the last one, bupropion can't be used with other smoking cessation medications, true or false? Okay, I'll go ahead and end polling. And I'll share the results just so we can take a look at what everyone said. So for the first one, a lot of folks said false. For varenicline will make me depressed. The second one, varenicline will give me mood swings. The majority of folks said true. And for the last one, majority of folks said bupropion can't be used with other smoking cessation medications, that was false as well. So let's take a look at these answers. So true or false, varenicline will make me depressed. So we know that this is false. There's no evidence that shows varenicline will increase the risk of depression. Common withdrawal symptoms that a person can feel when they are quitting while using varenicline are sadness and mood changes. And that is what can cause a person to feel depressed. So the second question, varenicline will give me mood swings. You said false, you were also correct. So some clinical trials, a lot of clinical trials have been done and proven that compared to a placebo, varenicline does not increase adverse neuropsychiatric events. Things like mood swings, irritability, and depression, these are all symptoms of nicotine withdrawal. And a person uses, as a person uses varenicline to quit, they might feel like these withdrawal symptoms as they're no longer smoking. And our last question, bupropion cannot be used with other smoking cessation medications. This is also false. Bupropion has been shown to be effective and safe in combination with the nicotine patch. So varenicline, also known as Chantix, this is a non-nicotine pill form smoking cessation medication. Varenicline is a partial agonist that is selective for nicotine acetylcholine receptors in the brain. This means that the medication fills receptors in the brain where nicotine would normally go when a cigarette is smoked, and the medication blocks the good effects of the cigarette. At the same time, it activates the receptors a little so that some of the good effects from smoking are still received. And this helps lower withdrawal symptoms from quitting smoking. Bupropion is an approved medication for treating depression. However, it's been found to be effective for smoking cessation because of its ability to increase dopamine levels in the nerve synapse by inhibiting reuptake of dopamine. So when a person smokes, the nicotine causes a release of dopamine, which enhances the pleasure-seeking pathways in the brain. And when a person quits or reduces smoking, nicotine is no longer stimulating those pathways. So bupropion counteracts this effect by inhibiting the reuptake of dopamine when a person experiences nicotine withdrawal. So there's a couple more knowledge checks right here. We're going to also test out some more knowledge on the other types of pharmacotherapy options for treating tobacco use. So on your screen, there's a poll in front of you. So true or false, I cannot use two NRT, two nicotine replacement treatment products together. Second true or false question, true or false, using nicotine replacement therapy is just as bad as smoking. And the last question, true or false, I can't smoke and use NRT, nicotine replacement treatment, or nicotine replacement therapy at the same time. Go ahead and end the polling right there and share some results. Okay, so the first one. Most folks said false. I cannot use two NRT products together. Okay. Second one, everybody said false. Using nicotine replacement therapy is just as bad as smoking. And the last one, majority of folks said false again. I can't smoke and use NRT at the same time. Well, let's take a look at the answers. True or false, I can't use two NRT products together. If you said false, you are correct. NRT products can be used safely together. It's actually recommended that a long-acting NRT like the nicotine patch, is used in combination with short-acting NRT. And this includes products like the nicotine lozenge, the nicotine gum, inhaler, or nasal spray. And we'll go over those in just a moment. The second question, using nicotine replacement therapy is just as bad as smoking. Everyone said false to this, and everyone is correct. It is the 7,000 plus chemicals in cigarettes that are the harmful part of smoking, not the nicotine. Nicotine is an added chemical that makes the cigarettes addictive. And the nicotine that a person consumes through NRT is considered clean nicotine. And the last question, I can't smoke and use NRT at the same time. The majority of folks said false for this one as well. And that is correct. All of these were false. We should rename this to false or false. But smoking while using NRT is safe. And a person can actually start using NRT even if they aren't ready to quit yet. If they're getting ready to consider it, they can start NRT while they are still smoking. So combination nicotine replacement therapy just means using two different nicotine replacement medications together. And it's recommended that using the 24-hour nicotine patch in combination with what's called a short-acting NRT. And those are those medications like the nicotine lozenge, like the gum, like the inhaler, like the nasal spray. So while the nicotine patch is slowly releasing nicotine into the body throughout the day, short-acting NRTs are providing quick bursts of nicotine to help reduce cravings. And these help limit withdrawal symptoms a person is feeling and expected to feel while they make a quit attempt. So looking at this table on the left, you'll notice the nicotine amounts in different types of tobacco products. This is on average the amount of nicotine in each of these products. And if you look at the table on the right, you'll notice the amounts of nicotine in a few common NRTs. These NRTs are designed to be used regularly and during a person's tobacco treatment. So based off of a person's nicotine dependency, amounts of NRT can be increased or decreased to provide that person with a comfortable medication level. So if a person is smoking, say, a pack a day, they'll typically have a higher dependency on nicotine and will need to have medication that matches that amount for what they're used to. So this will look like a higher dosage of the patch, the 21 milligram patch. And then if they're using the combination with that, using something like the 4 milligram lozenge to treat that higher dependency. NRT is often underutilized, and the patch should be used in combination with that short-acting NRT to get the best results. So looking at the long-term outcomes of using pharmacotherapies, all of the medication that we've reviewed has been observed in clinical trials and studies. So at 6 months, higher quit rates are reported while using all of these medications compared to placebos. The NRTs here have been observed on their own, and as we know, they also yield successful results when they're used together. And lastly, on the far right, varenicline is seen to result in the highest success of quit rates out of these medications. So we're going to switch from talking about medications over to the second method for treating tobacco use, and that is behavioral therapy and motivational counseling. So behavioral counseling allows providers to figure out what changes a person can make in order to achieve a desired behavior. So for smoking cessation, multiple in-depth counseling sessions are the most effective, but even brief counseling sessions can increase quit rates. And behavioral counseling really allows a provider and a patient to figure out ways to help cope with nicotine withdrawal symptoms and cravings. So for example, if a person is feeling irritable or angry as one of their withdrawal symptoms, coaching them through that, recommending taking a time out, taking space that's just for them, practicing deep, relaxing breaths as a way to manage that withdrawal symptom. It also gives space and time to identify some smoking triggers that person might be popping up for that person. So for example, if a person is, a common trigger for them is watching TV, that's when they really like to smoke a cigarette, or with their cup of coffee in the morning, they have to have a cigarette with that cup of coffee. That's a unique trigger for that person, and being able to identify that is important. Triggers aren't also only just people, places, or things. They can be hearing a certain song or a memory. So using behavioral therapy can help identify triggers that a person might not even realize that they had. It also helps a person cope with stressful or difficult situations. So if someone's has a really stressful job, and it's that's a time where they do find themselves smoking a lot to deal with that stress at their job, coping with that situation and altering that situation could look like just not taking those cigarettes to work, trying that out and see if that's something that's doable for that person. And in addition to that, following up with that, helping them try to avoid high-risk situations. So that could be being around other smokers, being in a place where they're really accustomed to smoking, like being at the bar, hanging out with their neighbors who usually smoke. And avoiding these high-risk situations could look like decreasing the time spent with those smokers to avoid even being in that situation in the first place. And lastly, behavioral counseling really helps a provider and a patient work together to address the unique barriers to quitting that person might be dealing with. So a very unique personal example of this could be that person is taking on the role of taking care of their aging parents. That's a hard, stressful situation to be in and a lot to take on. But working with that person to figure out maybe what's worked before in the past for them. Maybe they were in a situation before that was really hard to manage. How can they leverage their strengths and figure out what they've done before that they could use in this situation too, instead of using cigarettes to deal with this situation. So if you're thinking right now that there is no way that you have time to do any of that with the patient if you're a provider, behavioral counseling can be simplified. And one way that we can do that is by using the 5 A's. So the first step in using the 5 A's is just asking about tobacco use, asking the person about their current tobacco use and asking if they've ever considered making changes to their tobacco use. And this is followed up with advising the patient to quit and clearly communicating the importance of quitting when you're offering this advice. This is followed up with assessing the patient's readiness to quit and engage in a quit attempt. And then after that, assisting the person to make a quit attempt by creating a treatment or an action plan. And this is hopefully including medication and counseling together in it. And lastly, arranging in-person or telephone follow-up during that conversation to make sure that the person can have a follow-up visit and have time to be checked in on to see how their progress has been done. So here I'm going to show a short clip demonstrating what this can look like in just about 3 minutes.
So I'm going to prescribe some antibiotics for you. I think the cough and phlegm is a lung infection. Okay. And within a few days of taking these antibiotics, you should feel considerably better. Now, I'm hoping that we can talk about smoking today. Is that something you'd be comfortable to talk about?
Okay, sure.
How many cigarettes are you smoking per day right now?
I've cut down, I think, because of just not feeling well, so probably about 15 to 20 cigarettes.
Right. And it's been many years?
Gosh, about 20 years, yeah, a long time.
And you understand that quitting smoking will be the most effective thing that you could do to improve your health right now, particularly in the context of these lung infections. I think this is the 3rd one we've treated this year. Yeah,
it's just, I've tried in the past and I just get so cranky and angry and frustrated, and it makes it really hard to continue.
Right, so you found it tough. Is quitting smoking in the next 30 days something that is realistic for you?
Wow. I hadn't really thought about it, but I suppose I could give it a try.
And you mentioned being cranky and irritable. Those withdrawal symptoms are reasonably common, and there are ways in which we can help you to manage those withdrawal symptoms. Certainly the medications, of which we have a number of options, will minimize or eliminate the withdrawal symptoms. We have a number of nicotine replacement therapies, patch, gum, lozenge, and inhaler. And we also have 2 prescription medications, varenicline and bupropion, all of which are effective and all of which will mitigate those withdrawal symptoms. And then we have a number of counseling options as well, so we can provide you with some one-to-one support within the clinic, or we can refer you to a smoking cessation group, and then you have the option of using the telephone quit line, Quit Now services. So I can just simply do a fax referral to the Quit Now service, and they will contact you and set up a system of support to support you through a quit attempt.
I didn't know that they offered things like that. So yeah, I mean, I would definitely want some more support. That would be really helpful.
So we could certainly set up the quit line for you. What about medication? Does that interest you?
People say that the patch is really helpful, so that's something that I might be willing to consider.
The patch is a good option. It's been around a long time. It's safe. It at least doubles the likelihood of you being quit at 6 months after your quit attempt. So I think it's a good option. So what about a quit date? Have you thought of a time that you would like to make a quit attempt?
I'm hoping to feel better soon and be back at work next week. So, if I'm occupied during the day, I think that would be a good time for me to start.
So you make a quit attempt next week? Great. So we'll arrange to see you again, maybe around that time, and follow up and see how you're getting on.
Okay, that sounds good. Thank you.
So as you saw and heard in the video, this provider is able to maximize the short time that he has with the patient by using those 5 A's to really start and guide and end that conversation. And motivational interviewing is the second part of this treatment. And motivational interviewing is great to use for every individual who smokes, but it's essential to use for those who are not ready to quit yet. And this involves first establishing a connection with the individual and then exploring their feelings, beliefs, and values in order to help them work through ambivalence or conflicting motivations around quitting. So the goal of motivational interviewing is to help a person who smokes, understand their reasons for quitting and for smoking. Also to understand the relation of these to those values and goals, and to help them build their confidence to quit and stay quit. And just like in behavioral counseling, we have tools to guide the conversation. And a common tool to guide motivational interviewing is through what we call OARS, like the oars on a boat. So the O in OARS stands for open-ended questions. Asking a person, well, what are your feelings about quitting? Or you can form that statement or form that question more as a statement. Tell me more about how you're feeling about quitting. The A in OARS stands for affirming their strengths, really uplifting a person and pointing out something that they've done really well or something that they've been able to accomplish can help them feel more confident and also creates a supportive relationship between the two of you. And these can look like you've done a great job remembering to wear your nicotine patch every day this week. And these affirmations don't always have to be about smoking. Another example could be, you're really doing your best. The R in OARS stands for reflecting back comments. This is great active listening practice, and it gives the person the chance to agree with you or disagree with you, or even elaborate on what they've said. So this can look like, you've tried to quit before, but it sounds like you didn't really have the support you needed then. And lastly, the S in OARS stands for summarized discussion. Giving a short recap of what that person has said, make sure that you've got all the information that you need, and it helps transition the conversation into an action phase. So a summary could be, you're feeling overwhelmed. You've got a lot going on. You've tried to quit before, but didn't feel like you had enough support then. You've got some good reasons to quit, and it sounds like quitting smoking is something you're considering. So as the provider, that really sets you up in a place where you can ask that person what they would like to do next after that. And I'll show another short clip of what using OARS looks like in practice with a patient who smokes.
Watch what happens this time when the provider cues into what the parent is saying, empathizes with her situation, and attempts to work with the parent to find a solution that fits her needs.
So I wrote a prescription for antibiotics for Aiden.
Okay.
I did want to talk to you though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now, I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you're able to stop, but they don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
Yes. Yeah.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's on your to-do list, it's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should?
And I'll pause it right there just for the sake of time. But hopefully in this video, you notice the provider used parts of OARS during the entire conversation. So OARS does not need to be used in order of the letters that it spells out OARS in. They can be used throughout the conversation. But just like with pharmacotherapy, we want to show the efficacy of using behavioral therapy and motivational interviewing. So in this study, different arms received different levels of contact. And even looking at the group that received no contact versus the group that received just 3 minutes of contact, there was still an increase in abstinence rate in the group with minimal counseling. And we see that increase in abstinence rate increase as the intensity of counseling increases. And as said before, and the biggest takeaway here should be pharmacotherapy and behavioral therapy and motivational interviewing are recommended to be used together for the best results. It's recommended that nicotine replacement therapy or varenicline or bupropion be used for a minimum of 12 weeks. And both can be used for an additional of 12 weeks or up to a year. And while also using that medication, behavioral therapy and motivational counseling should be used for a minimum of 4 sessions on average of 12 weeks. However, like we saw in the chart before, even brief interventions are effective and highly recommended. So before I turn it over to Liz, I'll share some resources, some smoking cessation resources that are available in Chicago and Illinois. So for all of Illinois, the Illinois Quit Line is a free telephone service offering access to registered nurses, respiratory therapists, and certified tobacco treatment counselors. And if you're a provider and you're not specialized in tobacco treatment, this is a great resource to refer patients to. So in Chicago, the Respiratory Health Association supports the Courage to Quit program, Chicago Quits, and this offers in-person cessation counseling as well as tobacco counseling, telephone counseling services. And if you visit the Respiratory Health Association website, you can find in-person counseling near you and register for those sessions. You can also access their telephone service by calling their own tobacco cessation quit line. And in Chicago, the Howard Brown Health Clinic offers tobacco cessation services that are specifically designed for LGBTQ+ individuals. And they offer counseling tailored to this population, as well as cessation medications. And they also have a study going on called Project Adhere. And this is the first smoking cessation and medication adherence intervention for gay African-American men living with HIV and AIDS. That is something that patients can be enrolled in if they want to, if they're interested in that. And lastly, there's some virtual resources that can be accessed by smartphone. The NCI Quit Guide is a free app for iPhone and iPad users. It offers tobacco use tracking calendar, motivational reminders, information on improvements in health, tips for managing cravings. And it also connects folks to a social network of other smokers. And lastly, the Smoke Free Text is a free text messaging service for adults and young adults. And young adults here includes people 13 years of age or older. And this provides 3 to 5 texts a day to give encouragement, advice, and tips to help smokers quit and stay quit. And all a person needs to do is text quit to 47848 to sign up. And now I'll pass the rest over to Liz, who's going to share more about quitting during the pandemic.
Okay, thanks so much, Emma. And I did see that there was a question in the chat. So before I get started, I just wanted to address that. So Linda asked, can you explain the referral process from cancer center providers to your tobacco treatment team? And sure, absolutely. So our tobacco cessation program, as Emma mentioned, we're a part of the Lurie Cancer Center at Northwestern. So our program serves all of the oncology patients who use tobacco throughout the system. So any provider they can refer to us a number of ways. One is just through Epic, through our EHR system. They can just send us the patient's name, and then we take it from there. We also do a lot of proactive outreach, because one thing we have found is that while smokers are pretty unlikely to proactively contact our program, they are really, really receptive when someone reaches out to them to initiate this conversation. So we find that proactive outreach and kind of calling anyone who's referred a number of times to schedule that initial appointment, it really increases the rates at which patients engage through our program. But if anyone has more questions, I'm happy to talk about that at the end as well. And if anyone works with patients at NM, I'm happy to provide the details of how to get patients to us. Now, I did for the remainder of the presentation, I did just want to pivot a little bit and talk a bit about our tobacco team's experience over these past 8 or 10 months during the pandemic, and I wanted to share a couple lessons learned. So, obviously 2020 has been a really tough year for everybody, and I think it's required all of us to pay a little bit closer attention to our own physical and mental health, and it's also required everyone to pay attention to how our own behaviors affect our health and affect the health of our communities. And I think that has been felt particularly acutely by the population that we work with, of people who smoke. So the sort of ambivalence, the I want to quit, I don't want to quit, that is typical and characteristic of tobacco users is particularly heightened at this time. On one hand, COVID is at the forefront of everybody's minds, and the people that we work with, they know there's a pandemic going on, they need to quit smoking, and this is high on their list of reasons why they are interested in quitting. But then on the other hand, there's all this stuff going on in the world. It's a very stressful time and a very stressful year for virtually everyone, and a lot of people in a lot more ways than one. So at the same time, there's the idea of sacrificing the coping mechanism that is smoking. It seems just really hard to do, especially hard to do at this point in time. Oh, can you go to the next slide, Emma? Oh, thanks. So in terms of how smoking impacts someone's risk of contracting COVID or experiencing a severe case of it, ultimately more research is needed. And as we continue to learn about this disease, we'll continue to learn more. But studies have shown that there is an association. There was a systematic review that showed that people who smoke were 1.4 times more likely than non-smokers to have a severe case of COVID, and they were 2.4 times more likely to have to go into the ICU or required to be on a vent or to die. So this is something that people are continuing to look into. And I should mention that our program was originally funded by the National Cancer Institute Cancer Moonshot Grant, by one of those grants. And we received this grant along with 42 other NCI designated cancer centers around the country. And so what we've actually been doing over the past few months is pooling all of the data that all of these systems have collected about COVID positive patients. It's all de-identified data, but it's a large pool of patients. And we're looking more into this question of how smoking interacts with COVID. So that's just a little plug, but hopefully in the next couple months we'll have some exciting new or interesting new research about that. Okay, if you could go to the next slide. So the message for our patients is clear. People who smoke, they know they're at high risk for other pulmonary and cardiovascular diseases like COPD and diabetes, all of which are risk factors for COVID as well, or severe cases of COVID. So it's really important that the people that we work with know that that this is a risk as well, and to know that quitting can help. As Emma said, it's never too late to quit. So if people quit, it's likely that their body will begin to heal and be able to better respond to infections in general, and particularly COVID. But I think equally important to making people aware of the risk is providing them with the tools that they need to change behaviors. So that's kind of what I want to talk about next. So yeah, thanks. So I want to focus a little bit about on the relationship, on the complicated relationship between smoking and stress. So here we have sort of a simplified version of how these two things interact with each other. But to start, what we often hear from people is that smoking is a stress relief. That's one of the reasons why, it's one of their main triggers. And in part that makes sense, because after you smoke a cigarette, you do briefly have, there is a brief effect. You have improved mood and concentration, your muscles relax, decreased stress and anxiety. It is very temporary, but it is an effect of smoking. And that effect increases the psychological reliance on smoking, and it reinforces this habit. And then we get to increased nicotine dependence. Now, once someone is dependent on nicotine, they do experience nicotine withdrawal and cravings. And what's important about that is that those withdrawal symptoms and cravings, they induce more stress and anxiety. So that increases someone's perceived stress level, and then they smoke to get that effect. So it does kind of create this this cycle that reinforces that reinforce each other. And I think that's really important to highlight with our patients. Because it's not something a lot of people are aware of, but once people can start to gain insight about how this works, they can start to question the notion of whether smoking really is a good coping mechanism for managing their stress, or whether there are other things that we can do. And I'll also note that one of the strongest predictors of abstinence at 12 months, in the research studies that we do, one of the strongest predictors is how somebody rates their ability to cope with stress without smoking. So for people who this is a main trigger for, it's really one of the first things that we as tobacco treatment providers need to address with them, because they kind of have to get this under control before we can make additional behavior changes. All right, let's go on to the next one. So I just wanted to point out a couple of the tools that I find helpful in working through this with the patients who participate in our program. One of the ones that I find most helpful is deep breathing. Now, if you use that phrase, some people will chafe against it. Not everybody likes it, but what it is it can be anything. It can be slowed breathing, meditation, closing your eyes and taking a break, mindfulness, prayer. You can call it whatever you want, but slowing down, slowing your breath just for a few minutes at a time, it can really help your body calm naturally and lower the stress that you're experiencing. And the way that I often present this to patients to encourage them to try it is I say, you say that smoking relaxes you. Sure, part of that is the way that nicotine causes a dopamine release in your brain. But the other part of it is how you're breathing when you smoke. So think of how you typically breathe. You inhale slowly, you exhale slowly. So if you just do that breath, that alone can help you relax a little bit. Next slide, if you would. And I think the other really important thing to highlight for people who are trying to quit is that medications can help with stress. Both nicotine replacement therapy and varenicline or Chantix, they're safe and effective as pre-quit reduction strategies. So somebody does not need to be absolutely ready to quit, ready to throw away all of their cigarettes before they start medications. And using medications to start treatment, it can really help people gain control over their own addiction. They can feel more in control of when they smoke, and it can increase their self-efficacy in quitting. So here are a couple of things that I've heard from people who I've worked with. The nicotine patch takes the edge off and helps me not smoke while at work. Or I haven't completely quit, but my cravings are not as strong. So using medications can really help people feel more ready to quit in the end, even if they're not ready when they start medications. If you would go to the next one. Perfect. So here's just a summary of some of the biggest quick hit strategies for things to try with people when you're helping someone quit in a really stressful time, or when you're helping someone quit when they're experiencing a really stressful life event. First, always validate the person's experience. Recognize that it is a stressful time and this person does have a lot on their plate. But just coming to the table, coming to the visit is a really important first step that should be acknowledged. Providing insight on the relationship between smoking and stress can be really helpful. Can you tell me a little bit more about how you use smoking to cope with stress, and then work through that a little bit? Setting achievable goals and encouraging pre-quit use of medications is also really helpful. So just getting someone to start, why not start by trying to wear the patch for a full month? It can help you reduce your smoking now, and it might increase your chances of quitting later on. It might make you feel more ready to quit after a month. So those are just some of the things that we have found helpful. If you would go to the next slide. Oh, okay. So that was it. But we have a few minutes left. So Emma and I would be happy to take any questions or comments that anyone has. Hear about your experiences working with patients during these crazy times of 2020. We'd love to hear about them. And also, if anyone has any further questions, feel free to reach Emma or I. All of our contact information is below. All right, but thank you so much for your time.
We do have one question, or a question/comment. Someone wanted to know, have you heard of the company Carrot out of Redwood City, California, whose pivot program, I guess, is digitally based? So if you know of any other live coaching that can be done digitally.
Yeah, can you say the name of that company again?
Carrot out of Redwood City, California. They have a pivot program. It's the latest smoking cessation digital platform.
Oh, interesting. I don't know about that one specifically, but I will say I think we're going to be seeing a lot more digital platforms for giving smoking cessation counseling over the next couple of years. One thing this pandemic has done is it's kind of made everybody do a rapid shift to telemedicine, and we've always used online tools, mobile phone apps, text messaging programs to give our patients additional support to help them quit. But I think those tools are just going to continue to continue to improve. So we're certainly looking to take advantage of them. But I'll look up that one in Redwood City, I think it was. But I haven't heard of that.
We don't have any questions in the Q&A section, but I did get a question regarding sharing the slides.
Oh, absolutely. Yeah, we can send out these slides. Afterwards. We'll send you the PDF, Tarnika, and then if you want to distribute them, please do.
Sounds good.
All right. Thank you so much, everybody. Everybody have a great week. Happy Thanksgiving, however you're celebrating.
Happy Thanksgiving, everyone. Thanks so much for joining us today.